Professor Simhan. Thank you very much for accepting our invitation to do this interview. Could you kindly introduce yourself to our readers?
Sure. My name is Jay Simhan. I'm an assistant professor of urology, and I come from Philadelphia, where I work at the Einstein Healthcare Network, and I have a professor position within the Temple University Health System and the Fox Chase Cancer Center. Okay.
So, what brought you into the field of urologic trauma?
I think that's an excellent question. Urologic trauma also encompasses GU injury and GU reconstruction. And for me, I was really interested in pursuing a field where there just weren't a lot of surgeons that were tackling some of these acute surgical problems in many patients. And many patients were really treated with conservative measures instead of surgical treatments, just because surgical treatments weren't well described, nor well educated, nor well learned. And I felt like if I were well educated in those techniques, I could help benefit many patients.
Great. So I understand you were in a panel discussion yesterday
Yes.
about morbid obesity is not associated with worse outcome following surgery after renal cell cancer.
Yes.
So how, based on what, does this conclusion come?
So I think what Eunice is referring to is I was a part of a discussion in one of the sessions earlier at the meeting that looked at outcomes of renal cell carcinoma in patients that were obese against those patients that were not obese. And this was a large series out of the University of Wisconsin where Dr. Abel and some of his colleagues looked at a large series of obese patients and compared outcomes over a 13 to 14 year period. And what they showed was, interestingly, patients that were obese did not seem to have poorer outcomes following renal cell carcinoma treatment. And that's really in stark contrast to prior studies that were done in kidney cancer that showed that obese patients were at a higher risk of developing cancer. So what the Wisconsin group has shown is that even though they're at a higher risk of maybe developing cancer, their cancer-specific outcomes are equivalent, are the same to non-obese patients. So it's a very interesting study.
Is the conclusion set or further studies still needed?
Well, I think, like anything, I think the best way we can answer that question is if it was a prospective study and patients are followed long term. Of course, a limitation of the Wisconsin study was that it was a retrospective study, and I imagine that they are continuing to accrue prospective data now, and this will be an answer that we'll have shortly.
So currently, what are you and your team are doing? Like some new or exciting investigations underway or in plan?
In Philadelphia.
Yeah.
That's a great question. So my practice primarily focuses on GU trauma, reconstruction, and actually prosthetics. Several things that we're doing as it relates to reconstruction and trauma is looking at minimally invasive surgery for repair of ureteral trauma and ureteral strictures. So in fact, tomorrow we're presenting a novel video of techniques of how we do robotic ureteral reconstruction for high ureteral injuries. So we're presenting some of our data on Boari flap reconstruction and psoas hitch reconstruction done robotically in patients with good outcomes in our center in Philadelphia. That's one area that we're looking at that's exciting and new. Another area as it relates to prosthetics in particular is, I have a very busy practice with penile implants and artificial urinary sphincters, and what we're starting to do, and what we've done a fair amount of, most in our region, I would imagine, is alternative reservoir placement, alternative balloon placement, and we've really pushed the limits of testing where we can put these balloons in cadaveric experiments, but then we've also translated that to patients, and we've shown excellent results in patients getting alternative reservoir placements for penile implant surgery as well as artificial urinary sphincter surgery. And the other thing that we've done, which has really been cutting edge, is because of a huge sort of cancer-based practice that my partners have out of the Fox Chase Cancer Center, patients that are diagnosed with prostate cancer that might undergo prostatectomy or that are undergoing prostatectomy, if they also have concomitant refractory erectile dysfunction and has failed numerous medical treatments for it, we have done combined prostatectomy and inflatable penile prosthesis insertion at the same time. And we also have videos showing how you could do both the prostatectomy as well as the penile implantation at the same time. And I really think that too is a very cutting edge aspect of our practice in Philadelphia. Yeah.
So I can see that you are very passionate in what you are doing.
Yes.
So what do you love about surgery?
That's a good question. What I like most about surgery and what I like most about, I guess, the things that I operate on are most everything that I'm operating on is a quality of life problem. I'm not a cancer surgeon. I work with cancer surgeons, and many patients with cancer, and many patients even without cancer, have real quality of life problems. And many times the best treatment for such quality of life problems in urology, whether it's bad urethral strictures, bad ureteral strictures, curvature of the penis, erectile dysfunction, or even male stress incontinence, those are surgical problems. And for me, the happiest thing that I get out of surgery is here's a patient with a quality of life problem that surgery is able to fix their problem very quickly. And most of my patients have been suffering with their quality of life problem for years, not just days, weeks, or months, but for years. And so to offer them a surgical treatment that can fix them soon after their recovery, I think is something most of my patients are very happy that they get that opportunity.
That's great.
Yeah.
And I would like to thank you for
No, thank you.
organizing a specialist on contemporary management
Yes.
of ureteral stricture
Yes.
with Helen Moray.
Yes.
So what's new in this edition that you might want to recommend to medical students?
Right. I think, Dr. Mori and I co-guest edited this contemporary management of urethral strictures in practice. And, I think urethral stricture really is something that probably we don't talk enough about. I think this journal does a good job of talking about it, but I would say globally we don't do a good enough problem about talking about it. And this journal really looks at contemporary management options. Gone are the days where dilation is a good enough surgery to treat stricture problems. Nowadays, urethral reconstruction really is an excellent treatment for strictures, and I would say what's cutting edge in what we've presented is we've looked at sort of key treatments or key anatomic areas that urologists often struggle with, and we have gone through a very systematic approach and representation of how to treat these patients. For example, we've looked at pelvic fracture, how patients can be managed differently with pelvic fracture. We've looked at really refractory situations with radiation-induced strictures, how patients can be managed successfully with surgical intervention. We've also looked at penile strictures in particular, different types of buccal grafting and different techniques to buccal grafting. Again, buccal grafting itself sort of was reported in the 80s and then really popularized in the 90s and in the 2000s. But what we've tried to do is look at it in a contemporary way and try to show that really these are excellent treatments long-term for patients that suffer from these really serious problems.
It's wonderful. Thank you very much.
Thank you. Thank you very much.